Welcome back. If you're an orthopedic resident gearing up for those big postgraduate exams like the FRCS or your fellowship tests, then this deep dive is absolutely for you.
Yeah, we're aiming for a really high-yield session today.
We're going to drill down into the core techniques for total knee replacement. You know, things like alignment, those critical bone cuts, soft tissue balancing, and how to handle complications when they pop up.
Exactly. The goal here is to pull out the most essential facts, the stuff that gets tested often, and really help you differentiate your answers.
And just to be clear right at the start, this whole discussion is built around the fantastic Ortho Made Simple notes. You can find those online at mokyingren.sg.
And those notes, they were put together by Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore, and he successfully went through the FRCS and orthopedic surgeries from Edinburgh. So we're basically tapping into that proven exam wisdom.
Definitely. It's not just about knowing the steps, is it? It's understanding why you're doing what you're doing. We want those aha moments for you.
Precisely. Like why 6 degrees of valgus? And what changes if you see a hypoplastic lateral condyle? That kind of depth. That's what shows real understanding in an exam setting.
Okay, perfect. Let's dive in. Foundational principles first. We all know the patient wants less pain and better movement, but what are the key mechanical goals we have to achieve in a TKR?
Right. You absolutely need to know these four. First, restore the overall mechanical alignment of the limb. That's number one.
Okay.
Second, get that joint line perpendicular to the mechanical axis. Super important.
Perpendicular, got it.
Third, you have to achieve good soft tissue balance. Think rectangular, balanced gaps through the whole range of motion.
Makes sense. And the last one.
And finally, restore the normal Q angle and just the overall joint alignment, the way it should move.
Okay, 4 key mechanical goals. Now, restoring that mechanical axis brings up alignment philosophy. Can you contrast the two main ways people approach this?
Sure. The most common one, the one you see most often, is the mechanical axis method. Yeah. With this, you're cutting both the femur and the tibia, so they end up perpendicular to the overall mechanical axis, the MA. The aim is a straight leg, 0 degrees mechanical alignment.
Straightforward enough. What's the alternative then?
The alternative is the kinematic axis method. This one's a bit different. It tries to put the knee back to how it was before the arthritis, its natural state.
So not necessarily perfectly straight.
Exactly. You might accept a little deviation. Typically, you'd cut the femur in about 9 degrees of valgus and the tibia in 3 degrees of varus. The idea is to recreate that natural slight varus joint line around 3 degrees.
Interesting. Less common, you said.
Yeah, definitely less common than the straight mechanical alignment approach, but it's a philosophy you should be aware of.
Good to know. Okay, let's briefly touch on getting into the knee surgical approaches. If the standard medial parapatellar isn't quite enough, or if you're asked about muscle-sparing options.
Well, the key thing to remember revolves around the quads. The subvastus approach, that's known for preserving quad strength and, importantly, its blood supply. That's a great point to make.
Okay, preserves quads and midvastus.
The midvastus splits the vastus medialis.
Yeah.
The key fact there is that it preserves the lateral half of the VMO insertion, still muscle-sparing to a degree.
Right. And if those still don't give you enough room, what are the big guns, the extensile maneuvers?
Okay, if you're really struggling for exposure, you've got 3 main options you escalate through. First, the quad snip, then the VY turn down, which involves the whole extensor mechanism.
Right.
And the most extensive is the tibial tuberosity osteotomy, the TTO. That gives you massive exposure, but comes with its own potential issues, of course.
Okay, quad snip, VY turn down, TTO. Got it. So now we've got the exposure. Let's get to the real core of it.
Yeah.
The 5 essential bone cuts that set the alignment. Where do we start? Distal femur.
Yep. Cut number 1.
Oh.
The distal femur cut. This is done in the coronal plane, and honestly, it sets the foundation for everything else.
Okay.
You'll typically use an intramedullary jig, an IM jig, and you set it to about 6 degrees of valgus.
Why 6 degrees specifically?
That 6 degrees is the average difference between the femur's anatomical axis, the AA, and its mechanical axis, the MA. So setting the jig to 6 degrees valgus relative to the AA makes your cut perpendicular to the MA. That's the key.
Okay, that makes sense. Are there times you wouldn't use 6 degrees?
Absolutely. Here's a classic exam point. In a valgus knee, particularly if that lateral femoral condyle nucleus is underdeveloped, hypoplastic.
Right.
You need to cut less valgus, maybe 3 or 4 degrees. If you cut the standard 6, you risk over-resecting medially and causing instability when you balance ligaments.
Good point. Any other factors?
Yeah, just a general observation.
Yeah.
Taller individuals often have a slightly smaller angle between their AA and MA, so you might dial it down a degree or so for them too.
Okay, distal femur, cut done. Now the anterior and posterior cuts, these are often done together with a 4-in-1 block, right? And
Yeah.
they set rotation.
Exactly. These cuts determine the femoral component's rotation, and getting this wrong, especially internal rotation, is a major problem. So you need reliable references.
What are the main references we use? There are 3 key ones, aren't there?
Yep, 3 lines you absolutely need to check before you pin that block and make the cuts. First is Whiteside's AP line.
Okay, define that one.
That's the line running from the deepest part of the trochlear groove, anteriorly, straight back to the center of the intercondylar notch, posteriorly.
Got it. Second.
Second is the transepicondylar axis, or TEA. Your final cut surface should be parallel to this line connecting the medial and lateral epicondyles.
Parallel to the TEA. And the third.
The third is the posterior condylar axis. This is the line across the most prominent points of the posterior condyles. Now, your cut isn't parallel to this one. Typically, you aim for 3 degrees of external rotation relative to this posterior condylar line.
Why 3 degrees external relative to that one?
Because the tibia, specifically the tibial plateau, usually has about 3 degrees of varus built into it. Adding 3 degrees of external rotation on the femur helps match this, creating more balanced flexion gaps.
Okay, that ties it together. Is there a situation where one of these references is unreliable?
Definitely. Big caveat here. In a valgus knee with lateral condyle hypoplasia, like we mentioned before,
Yeah.
do not use the posterior condyles as your primary reference. They're deformed. Relying on them will almost certainly lead you to internally rotate the femoral component. Use Whiteside's line or the TEA instead.
Crucial point. Okay, that covers femoral rotation. Let's move down to the tibia. Cut number 4, the proximal tibial cut.
Right. This one's usually done using an extramedullary or EM jig.
Yeah.
And unlike the femur and the tibia, the anatomical axis and the mechanical axis are pretty much the same thing.
Oh, that simplifies things.
It does. So you just aim to cut perpendicular to that tibial AAMA. This cut controls your varus valgus alignment in the coronal plane.
And a poop slope.
And importantly, yes, it also sets the posterior tibial slope in the sagittal plane. The usual target here is somewhere between 3 to 5 degrees of posterior slope. Some say 0 to 7, but 3 to 5 is a common goal.
Okay, distal femur, anterior, posterior femur, proximal tibia. That's 4. What's the 5th cut?
The 5th cut is the patella, resurfacing the patella.
Right. What's the key principle there? Just take off the arthritic surface.
Not just removal, it's about restoration. You want to cut just enough bone so that when you add the thickness of your patellar button implant, the total thickness matches the patient's original pre-disease patellar thickness.
Is there a target thickness?
Yeah, typically you're aiming for that combined bone plus implant thickness to be around 10 to 12 millimeters. If you resect too much bone, say leaving less than 12, 14 millimeters of native bone, you significantly increase the risk of a patellar fracture later on.
Okay. Restore original thickness, avoid over-resection. Got it. Perfect. That covers the 5 cuts. Just a reminder for everyone listening, we're breaking down these high-yield TKR concepts based on the OrthoMade Simple Notes from mokyingren.sg. We're aiming to really solidify this for your exam prep as we move into the next crucial area, gap balancing and referencing.
Right, so we've made the cuts, or at least planned them.
Yeah.
Now, how do we actually size the femoral component relative to those cuts? This brings up anterior versus posterior referencing. What's the difference in the trade-off?
Okay, with anterior referencing, the system fixes the anterior cut position first, usually using a stylus or boom off the anterior cortex. Then the posterior cut is determined by the implant size chosen.
And the main benefit there.
The big plus is that it reliably prevents notching the anterior femoral cortex, which we know weakens the bone. That's a key safety aspect.
But there's a downside.
The risk is that by fixing the anterior position, you might end up altering the posterior condylar offset depending on the size chosen, potentially making your flexion gap too loose or too tight relative to your extension gap. The author of the notes, Dr. Mok, mentions he generally uses this method, though.
Okay, so what about posterior referencing?
That's the opposite. It references off the posterior condyles first. You determine the posterior cut, and then the anterior cut is set based on the implant size.
So the advantage is better control over the flexion gap size because you're directly referencing the structures that define it. But the major drawback, the thing that makes surgeons nervous,
is the risk of anterior notching.
Exactly. If you choose a slightly smaller size or the anatomy is tricky, you run a much higher risk of accidentally cutting into that anterior cortex.
Okay, so a clear trade-off between preventing notching and controlling the flexion gap. Now, the bigger picture debate, measured resection versus gap balancing. Is one truly better?
The classic debate. So measured resection, MR, means you make your bone cuts based purely on bony landmarks and average anatomical measurements, like that 6-degree distal femur cut or 3-degree external rotation.
Right, based on the bones.
Gap balancing, GB, on the other hand, prioritizes the soft tissues. You might make an initial cut, then use tensors or lamina spreaders to equalize the tension in the medial and lateral ligaments in both flexion and extension first, and then adjust your final bone cuts to match that balanced ligament tension.
So, does the evidence favor one? What should you say in an exam?
Well, this is the key takeaway. Despite lots of studies and strong opinions on both sides, meta-analyses have consistently shown no significant difference between MR and GB in terms of long-term patient outcomes, function, or implant survival.
No difference. That's definitive.
Pretty much. So, while you should understand both techniques, you can confidently state that the evidence doesn't clearly favor one over the other for outcomes. Technique preference often comes down to surgeon training and philosophy.
Okay. Let's say we primarily used measured resection. We still need to check our gaps, right? We need McPherson's rule. Equal rectangular gaps in both flexion and extension. What parts of the surgery control each gap?
Good question. The flexion gap, the space when the knee is bent, is mainly determined by three things: the size of your posterior femoral resection, the level of your tibial cut, and the integrity or handling of the PCL, if you're keeping it.
So if the flexion gap is too tight?
If it's tight and you're doing a CR knee, the first thing you look at is carefully releasing some fibers of the PCL until it balances. If it's a PS knee, you check your posterior femoral cut or implant size.
Okay. And the extension gap knee straight?
The extension gap is controlled by the distal femoral cut level, again the tibial cut level, and critically the tightness of the posterior capsule.
Right, posterior capsule.
If the extension gap is tight, you often need to release that posterior capsule carefully.
This leads directly into troubleshooting instability scenario. You've made your cuts, put in the trial implants, and the knee feels loose in extension. What happened? What's the fix?
A loose extension gap almost always means one thing. You took too much bone off the distal femur. Excessive distal femoral resection.
And the solution?
The solution is you need to add back that height. You need to use distal femoral augments on your trial component, and likely on the final one too, to restore the joint line and tension the gap correctly.
Makes sense. What about the opposite problem, loose inflection?
A loose flexion gap usually points to a couple of possibilities. Maybe the femoral component is simply too small, undersized anteroposteriorly, or if it's a CR knee, the PCL might be incompetent or over-released, or maybe put in too much posterior tibial slope.
And how do you address that?
Well, if it's sizing, you might need a larger femoral component. If it's PCL or slope-related, you might consider augmenting the posterior femoral condyles, or even carefully shifting the femoral component a bit posteriorly, being mindful again of that notching risk.
Okay, great troubleshooting points. Let's pivot now to some specific complications and scenarios that often come up. Fixed flexion deformity, FFD. How do we manage that intraoperatively?
FFD needs more space and extension.
Yeah.
So the primary strategy is to resect more distal femur. The classic rule of thumb, good for exams, is to take an extra 2 millimeters of distal femur for every 10 degrees of preoperative FFD.
2 millimeter per 10 degrees. Got it. What about releasing tight posterior structures? Is there a sequence?
Yes, there's a specific testable sequence for releasing posterior tightness causing FFD. First, remove any large posterior osteophytes. If still tight, then release the posterior capsule from the femur. And if that's still not enough, the final step is carefully releasing the origins of the gastrocnemius muscle heads.
Osteophytes, posterior capsule, gastroc heads. Okay, let's talk patella again. Specifically, patellar clunk syndrome. We see this more in PS knees, right? What's actually happening?
Yeah, it's more common in PS designs. What happens is a little fibrous nodule, like scar tissue, forms right at the junction between the top of the patella implant or remaining bone and the quadriceps tendon.
And that causes?
As the knee extends from about 90 degrees flexion, when it gets to around 40 degrees, that nodule gets caught in the intercondylar box of the femoral component. Then as extension continues, it suddenly snaps free, causing a palpable, often painful clunk.
How would a patient describe it? What do you look for?
They'll complain of anterior knee pain, and specifically that catching or snapping sensation as they straighten their leg, usually when getting up from a chair. You can often feel it yourself during examination around that 30-40 degree extension mark.
Are there risk factors we should note?
Yes. Preoperative patella baja is one. Using a PS implant rather than a CR implant is another known factor. And also, if the surgeon used a femoral component with an increased posterior condylar offset, That can make the box more prominent anteriorly and increase the risk.
Interesting. What about patellar denervation? Does cutting the nerves around the patella help with anterior knee pain after TKR?
Ah, that's controversial. There was hope it would reduce pain, but a significant study, Gupta et al., in GBJS back in 2010, showed basically no difference in pain outcomes between patients who had patellar denervation and those who didn't. So the evidence isn't really there to support doing it routinely.
Good to know the evidence. Okay, safety point. Popliteal artery injury. It's rare but devastating. How do we avoid it? Where does that retractor go?
Critical point. You must keep retractors, especially sharp ones like a single-prong Hohmann, medial to the PCL insertion on the tibia. The popliteal artery runs lateral to the PCL at the joint line level. Staying medial keeps you away from it.
And does knee position help?
Yes, flexing the knee also helps. Flexion naturally moves the neurovascular structures more posteriorly, further away from the cutting zone. So keep the knee flexed during posterior work.
Medial to PCL. Keep the knee flexed. Okay. What about doing a TKR in someone who's had their patella removed previously, a patelectomy? What's a common finding?
The most common issue you'll see clinically after patelectomy is an extensor lag difficulty fully straightening the knee actively. The TKR itself can be more challenging too, often needing augmentation or specific components.
And why might someone have had a patelectomy in the first place? It's not common now, is it?
No, much less common. Indications today are really limited. Things like maybe severe osteomyelitis of the patella that couldn't be cleared, extremely comminuted fractures that are just impossible to fix, or perhaps certain patellar tumors.
Right. Another challenging group. TKR in obese patients, say BMI over 30 or 35. What are the key risks and considerations?
Yeah, obesity definitely increases risks. You need to counsel patients about and be prepared for a higher risk of infection, both superficial and deep. There's also an increased risk of aseptic loosening and overall higher revision rates compared to non-obese patients.
What about intra-op? Anything specific?
Intraoperatively, you might need a longer incision just for adequate exposure. Very important. Make sure IV antibiotics are dosed appropriately for their weight, not just a standard dose. And aggressive DVT prophylaxis post-op is essential.
Do stems help? Is there a role for using prophylactic stemmed components in obese patients to reduce loosening risk?
That's been debated a lot. There was a study by Steer and colleagues in 2018 looking specifically at patients with BMI over 35. They actually found no significant difference in failure rates whether they used standard components or components with stems.
Really? No difference?
Statistically, no difference in that study. It suggests that while stems might seem intuitive, meticulous surgical technique and achieving good initial fixation might be more important than simply adding a stem by default in obese patients. But it's still debated.
Fascinating. Okay, let's shift to our final section, evidence-based blood loss management. First off, what's a typical blood loss we expect in a standard TKR?
You should expect a total blood loss somewhere in the range of 500 milliliters to about 1 liter. That usually translates to a drop in hemoglobin of about 1 to 3 GDL postoperatively.
Okay. Tranexamic acid, TXA, is it standard practice now?
Oh, absolutely. The evidence for TXA is overwhelming. It significantly reduces blood loss and the need for blood transfusions. It's basically standard of care.
What's the recommended dose or regimen?
The NICE guidelines, for example, recommend a combined approach. 1 gram of 5-ETXA given before incision or inflation of the tourniquet, and then another 1 gram given intra-articularly, like in the joint space, just before closing after the final washout.
Okay, IV and intra-articular TXA. Now, the classic question, drains. Should we use them routinely after TKR?
The evidence-based answer, the one you should give in an exam, is no, do not routinely insert a drain.
And the evidence for that.
You should be ready to mention the Cochrane Review by Martin Parker back in 2007. It looked at multiple studies and found no difference in complications like infection or hematoma formation, whether a drain was used or not. But, importantly, the group with drains actually received more blood transfusions.
More transfusions with drains. Okay, that's counterintuitive but clear.
Exactly. So the evidence supports not using a drain routinely.
Last point on blood. The tourniquet. Everyone uses one for a bloodless field, but does it actually reduce the total blood loss or transfusion rate?
That's another interesting one. Tourniquets definitely reduce the bleeding during the surgery and immediately after deflation. That makes the operation easier. However, studies suggest they don't actually decrease the overall blood loss measured over 24 hours, nor do they significantly decrease the actual transfusion rates.
So it helps with visualization, but maybe not the overall blood balance.
Precisely. There's even some debate about potential downsides like increased DVT risk or thigh pain, though that's less clear-cut. But for transfusion rates, the evidence suggests tourniquets don't make a major difference.
Okay, that's a really practical wrap-up on blood management. So we've covered a lot of ground today. Alignment goals, those crucial 5 cuts, referencing gap balancing principles, handling tough scenarios like FFD and patellar clunk, and the latest on blood conservation, all high-yield stuff.
Definitely. And maybe a final thought to leave you with as you prepare for your exams. Mastering these technical steps, the cuts, the numbers, the alignment, that's absolutely essential. You have to know it cold. But remember, TKR isn't just carpentry.
Right.
Things like navigation and robotics can help get the bone cuts accurate, sure, but they shift the focus even more towards understanding and managing the soft tissues, the ligament balancing. That's where the real art, and often the difference between a good and a great outcome, lies. So study the techniques, but also think deeply about the decision-making around balancing those soft tissue envelopes.
That's a fantastic point. It's about judgment, not just measurement. A perfect reminder as residents head into these exams. And once again, a big thank you for this deep dive, which was structured around the invaluable ortho-made simple notes available on mokyingren.sg.
It's been a pleasure. And as you continue putting in the hard work, remember that diligence and applying knowledge with good sense are key. We pray you're blessed with clarity, focus, and the strength you need as you prepare to use these skills to serve your patients well.
Well said. Until our next deep dive, keep studying, stay focused, and all the best with your preparations.